Utilizers, welcome to my channel. I am Courtney Noel, and clearly I am Courtney Noel. If you're new to my channel, welcome, welcome, welcome. And if you are an oldie but a goldie, hey girl, hey boy, hey, welcome back to my channel. As you guys know, I told you I was going to be rolling that utilization review content out. So if you see me with this white coat, this symbolizes we're going to be talking about utilization review or case management. So if you are like, child, I saw the title and I need to know what's the difference between Interqual and MCG, aka Milliman. If you like, child, what is Interqual and Milliman or MCG? Or if you just want to be plain old nosy, go ahead and stay tuned to this video. Please don't forget to like and subscribe and ring my bell. Ring my bell. My bell. Ring-a-ling-a-ling. Ring my bell so you can stay notified of my weekly videos. Alright guys, so let's get into it. We are going to talk about Interqual versus Milliman. And I shouldn't say versus because they're not in competition, but they are like the two most popular guidelines that are used across the nation. So when I say guidelines, aka criteria, I might use them interchangeably even though they're not, but for the purpose of this video, they're going to be used interchangeably. Ugh. So guidelines are basically criteria that we use to determine the appropriate levels of care, goal length of stay, and interventions patients should be getting while they are under our care and during that specific admission. And these criteria and guidelines are guided by diagnoses. So if a patient has a chest pain, we should be seeing this. If a patient has cellulitis, we should be seeing this. Or if a patient has pneumonia, we should be seeing this. So that's what these criteria tells us, so that way we can make sure that this patient is progressing along in our care and utilizing the appropriate resources and moving through in a timely fashion. So it's basically like checks and balances for us as providers, and also for insurances or payers, that's what we call them, as payers, to make sure or to understand and make sure that we are doing what we're supposed to do as a facility providing care to their members, aka patients. One thing I should note is that typically guidelines or criteria, MCG, Interqual, they have some others, they are used by managed care. So they're used for insured patients. When it comes to your straight Medicare patients or your straight Medicaid patients, I'm going to refer you back to your facility, but I have seen from the provider side that typically you review those cases with Interqual, and remember there's always the 2 midnight rule that goes along with your Medicare patients. That's a whole nother ball game. Okay, so the similarities of Interqual and MCG. And for this video, I will be saying MCG or Milliman, and that they're interchangeable as well. So similarities, they all have common diagnoses built in, because that is where the data comes from. You have your chest pain diagnosis, your cellulitis, your pneumonias, your sepsis, the list goes on and on and on, but they all have them built in. But there are some times when you get these patients and they don't fit into a box. Both criterias, Interqual, Milliman, both criteria or both guidelines have, let me say guidelines. Both guidelines have general diagnoses, or aka your catch-alls. So that makes them similar in that respect. They both have resources. So you may be in Interqual and you're reviewing a cellulitis patient, and they may have some little notes in there, or you can always refer to the bottom of their screen or bottom of your screen, and it'll tell you why they have the interventions or why they're requiring what they're requiring. And they also may refer you to certain journals or medical articles that support their reasoning. The same goes for MCG. They have resources to support, they have resources to support why they are saying this is how your patient should be progressing through care. And both have ways to determine which level is appropriate. So for Milliman, they only go into observation versus inpatient. If you don't understand what appropriate level of care is, go ahead and click this video here, and it goes more in depth about what an appropriate level of care is. Watch that and come on back here, child, so you can be up to date with what I'm trying to say. Now let's get into the differences of the two. So I'm going to first talk about MCG. MCG with reviewers, when I say reviewers, I mean utilization reviewers, we have always seen MCG as a more lenient, or I wouldn't say lenient, but a more comprehensive guideline to use, because it wasn't so strict. It would give you certain parameters. Like for instance, for anemia, at one point it would say, okay, this patient may be meeting inpatient level of care if you're seeing decrease in hematocrit over a certain time. Okay, so so you might have somebody who came in with 11 hemoglobin or 20 something hematocrit, and then they drop down to and you see a trend of dropping down, then you know that the patient has some bleeding. So that's where the leniency, it doesn't give you dead numbers it needs to be on to meet that criteria point. Okay, another thing about care days. So in Milliman and MCG, a care day is not determined by how many physical days the patient is in the hospital, but how the patient is progressing through their stay, through their admission. So you can have a patient who may be in the facility for 3 physical days, but they may be on care day 2 because they haven't met that milestone to progress to the next level within that mission, the next level of care that they have there. So that's something different about MCG. Another thing about MCG, when a patient doesn't hit those mile markers or those milestones to progress to the next care day, then you have what is called a variance. And a variance is what you let the system know, hey, it's a variance. This patient didn't meet it because of medical or because of system, your healthcare system. And I think this is good because it reminds the reviewer, which is us, to look for avoidable delays, aka avoidable days, and make sure that you're documenting those. Y'all let me know in the comment box below if you know what I mean when I say avoidable delays and avoidable days, because I might need to go over that. But yeah, that's why I like variances, even though it's a little alarming because you're like, dang, I don't want to be putting all this information in this system. But I think it helps keep track of those variances, aka avoidable days, avoidable delays that are happening. It reminds the reviewer to document those things. So I do like that aspect. So that's what's a little bit different about MCG. Now let's talk about what's different when it comes to Interqual. When I first started, Interqual. So when I first started utilization review, Interqual was some people, the reviewer nurses who was teaching me, they was like, girl, I really don't like the review of Interqual, But, I mean, it is what it is. The reason why a lot of people don't like to review with Interqual is because it is more strict and more detailed. So what MCG will say is, patient should have decreasing decreasing hematocrit despite observation level intervention. So the patient may have gotten a blood product, or the patient may have gotten fluids, anything to bring that fluid volume back up. And now at this point, when you're looking to see if this patient meets inpatient level of care, the hematocrit is continuing to decrease. They're showing a trend, so therefore the bleeding is definitely happening. So they meet in inpatient level of care. That's what MCG will say. Whereas with Interqual, it will say, baby, if it ain't below 7, hemoglobin is not below 7, baby, this is OBS. That's how direct. So it has to hit all points in order to meet an inpatient level of care or an observation level of care. Another thing that is different with Interqual is that you will have an observation tab, then you'll have a acute tab, and then it'll go to you have an acute tab, and then it'll go to it'll say acute, or then it'll say intermediate, and then it'll say critical. And that kind of threw me off in the beginning because I was like, well, which one is it? But just remember that there are 2 levels of care that we specifically deal with. That's inpatient and observation. Baby, if it ain't either or of those, it ain't no level of care. You understand what I'm saying? So don't let that throw you off when you get to interqual. Anything under acute, whether it's intermediate, critical, or just acute in general, it's inpatient level of care. Okay, so when it comes to interqual and the progression of days, so remember in MCG I said that you could be on physical day 3 and then still remain in care day 2 because the patient hasn't progressed through that care day, that milestone. That's not the case for interqual. For interqual, the progression is determined by the physical days that the patient was there. So your patient may have been here in observation day 1, then the patient was a partial responder, but the criteria requires for them to spend another day in observation. So it's physically day 2. Then you get to day 3 and it's like, child, this patient he ain't responding. Then you're going to look at the criteria and it's going to say, okay, well, you are on observation day 3. If the patient is a partial responder, then progress to that diagnosis day 3. And then that's you review that criteria to see if the patient met there. So that's the difference between the two. Here, you can't progress if you don't hit a milestone in whatever care day. Whereas in interqual, you're going to keep on running those you're going to run through your physical days to determine where your patient should be in that progression of care. So I hope that makes sense. Y'all let me know in the comment box if that makes sense. So the question remains, the questions that I get is, number 1, what do I think? Which criteria is better? Honestly, at this point, maybe back in my younger utilization review days, I would have probably leaned towards MCG. But to be honest, these payers have tightened up. And baby, it's hard to meet an inpatient level of care. 9 times out of 10, if your patient is not really sick, 9 times out of 10, they want that patient in obs. And I know it sounds crazy because observation is less money for the provider, for the facilities, the hospitals, but that's where these criteria are leaning towards, especially since y'all know, child, uniting a person is interqual. So you already know them criteria is strict, okay? I ain't want to gossip in here for me. Also, my newer nurses, they get discouraged. They're like, oh my gosh, I can't make it meet. I can't make it meet. It's not your job to make it meet. If you can't make it meet, it is not a defeat. Don't try to make these things meet. It is, remember, these are patients and things happen, and we are here to determine that the resources are being utilized in an appropriate manner. So if you cannot make a patient meet, it's not a defeat. You need to refer to the stop gates or to the process that your facility has. So for me, always remember that at the end of the day, these are guidelines. These are not strict rules. These are guidelines, and guidelines keep us in our lane, but we are dealing with patients, and ultimately the physician's judgment is king, okay? If a physician says to you, hey, I'm treating this patient and I feel like this patient needs to be inpatient level of care, you say, okay, doctor, that's beautiful. Please document your medical necessity, okay? That is what it boils down to. The end of the day, your physician's judgment and the medical necessity for this patient being here. So you're probably like, okay, girl, what? Like, how does that work? So I'm gonna give you a scenario. Say, for instance, you have a patient that's on your census. We all know observation hours are a big deal because the longer a patient is in observation, the less money that your hospital makes. Let's just be clear, because they get reimbursed from these payers less money. So say you have a patient that is observation level, has been in observation level of care 48 hours of chest pain. Or no, let's do cellulitis because that could be a little bit better. So, okay, they've been here for cellulitis. You have your physician has done his cultures. The patient is getting IV antibiotics, and you're at 48 hours of care. So you're going to number one, see if the physician has made any notes. And if he hasn't made any notes, you're going to pick up you're going to pick up the phone and call your physician and say, hey, Dr. So-and-so, patient Smith that was in here for cellulitis from a cat bite. Listen, it's 48 hours obs and it's not me inpatient level of care. What is your plan of care for this patient? He or she may say to you, listen, that patient, their legs still big, like the swelling has not gone down. They have been on IV antibiotics. They have a low-grade fever. I don't feel comfortable sending that patient home. You're going to say, okay, that's perfect. Can you please document that? Can you please document medical necessity and also document that the patient has not progressed, improved since we have been doing interventions? Okay, that's one way you can handle it. But say the doctor, you call the doctor and he like, well, you know, he is in inpatient level of care. Okay, well, you know what? I was going to discharge him today anyway. Perfect. You got the patient out. That is how you're going to help determine when these patients get to these change points and these places where it needs to be determined if they're going to be rolled to inpatient or remain at observation level of care. So remember, if you cannot make it meet, it's not a defeat. You need to, number one, understand the plan of care of your patient. Understand what the physician is trying to do, and refer, if you have the opportunity, refer to your physician advisors for a secondary review. Alright guys, so I hope that made sense. If it didn't, drop me some comments in the comments box so I can help clarify some things. You might have to listen to this video more than once because it's a different kind of concept to grasp, especially if you are newer in the utilization review space. Make sure you guys check my description box. Follow me on Instagram. Most importantly, I want you to know that I love you, but Jesus, he loves you so much more. God bless you.